I now invite Dr. Muhammad Shaloob.
I am presenting an interesting case which we had recently. I am presenting a rare case of primary angioplasty done in Apollo Hospital, Secunderabad. This was a 37-year-old gentleman who presented to our emergency room on a Sunday afternoon with history of chest pain of half an hour duration associated with profuse sweating and vomiting. He is complaining of mild dyspnea. There was no cardiac risk factors apart from smoking. On examination, he was hemodynamically stable. Pulse rate was 100 per minute. BP was 130 by 80 millimeter mercury. Respiratory system examination, bilateral air entry was present. Few basal crypts was present. Cardiovascular system examination was unremarkable. ECG taken showed extensive STEMI in anterior leads. 2D echo done showed regional wall motion abnormality in the LAD territory with fair LV systolic function. After getting an informed consent for a primary angioplasty, we shifted the patient to the cath lab. As the patient was put on the cath lab, he became acutely dyspneic and was complaining of severe chest pain. We went ahead with the angiogram. Systolic BP at the start of the procedure was 90 millimeter mercury. Respiratory system examination at this time showed bilateral crypts involving up to 2/3 of the lung fields. First, we took a right coronary shot diagnostic, which showed a dominant RCA. Then we took a left shot because patient started deteriorating and his BP came down to 60 millimeter mercury. To our astonishment, this is what we saw. Now we know that we had a big problem in our hand. Without wasting much time, we immediately took a BMW wire and crossed the LMCA lesion and parked the wire distally in the LAD. Then we used a Medtronic export catheter, which we usually use, and done a couple of aspiration run. The check shot subsequently showed no flow in the left main. So we were in a dilemma. What to do next? Whether to predilate the balloon, whether to give intracoronary GP2B3A inhibitors, or whether to do intracoronary thrombolysis. The wire had gone fairly smoothly, hence we knew that there was not much role in predilatation. And there is much less evidence for intracoronary GP2B3A inhibitors or intracoronary thrombolysis. At this point, we had a newer aspiration catheter in our with us, which is a TVAC aspiration catheter, thrombus vacuum aspiration catheter. The plus point of this aspiration catheter is it has a wide aspiration port compared to the normal Medtronic export catheter, and it uses 60 ml syringe, unlike 20 ml in export. So it gives a higher negative pressure for a longer time, hence more thrombus can be sucked. So So this is the Nipro catheter. We did a couple of runs. And subsequent shot, you can see that the flow has been achieved in the left main and LAD, but the thrombus has shifted now to the circumflex, and there is a no flow or slow flow in the circumflex. So we immediately wired the circumflex, and since we usually use a export catheter, we thought we'll go ahead again with an export aspiration catheter and do aspiration of the circumflex. So this was the shot after using export catheter. You can see the thrombus is still there and there is significant slow flow. So we again went ahead with the Nipro catheter here, and we did a couple of runs. Subsequently, you can see there is a good TME3 flow in the circumflex with no residual stenosis. And the LAD is also showing a TME3 flow. At this point, the patient improved symptomatically and his blood pressure was now around 90 millimeter mercury. As a precaution, we put the patient on an IABP and was shifted to the ICU. Next day, we did take a check shot which showed TME3 flow in the circumflex and LAD with no significant residual stenosis. The patient was slowly weaned off the IABP and was discharged 10 days later. He is on follow-up and he is doing well. So just wanted to tell that STMI with the culprit lesion in the left main artery is a rare cardiac emergency. Only few are fortunate enough to reach the cath lab and even then could have potential catastrophic outcome. The success is in immediate detection and intervention. Larger thrombosuction device may be beneficial in case with larger thrombus burden. Thank you.
Thank you, Dr. Shaloob. That was a wonderful case. Any questions from the audience?
Yeah, just
Yes.
tell us about this new suction catheter, the larger profile.
What is the expression catheter you use?
It's called a TVAC catheter. It's a thrombus a vacuum aspiration catheter. It's from Nipro, Japanese-based company. There's a trial which was published in JACC in 2008, which has showed, which compared thrombosuction with this particular aspiration catheter and PCI and showed good aspiration, good end results.
What is the profile of this catheter?
It has a duck bell shape at the distal end, and it has a wider area, about 5.9. Actually, we used a 6 French one because we used a 6 French guiding. There is a 7 French one also. So the inner diameter at the proximal end is also higher in 7 French, 0.90. So and the other thing is that it uses a larger syringe, vacuum syringe, so it maintains a higher negative pressure for a longer time.
Any other questions? Yes, yes, sir.
Okay, I'll just tell about that export catheter because I used that one. It has got two things. One is the suction, the diameter. What happens is in export it is 0.39. I'm sorry, 3.9. Whereas in this Nero it is 5.9. So the hole from which we suck the clot, it is larger lumen, and that it is dumbbell shape. The shape is different. And similarly, the suction, the capacity is 60 ml. Compared to the normally what we have at 20 ml. So it gets a better vacuum pressure. Of course, it is available in 6 French as well as in 7 French, but that's the advantage of using in these high clot situations.
Yes, sir.
Did you investigate any thrombotic tendency except that smoking history, lot of thrombus burden?
Thing is that he is on follow-up, and because he is not that affordable to do all the coagulation. He is on follow-up and he is doing well. So we thought it is more of thrombus being a smoker and things like that.
There must be some reason because many times, sometimes homocysteine, all these things have to be investigated.
Yes, your point is made, sir. Thrombophilia workup was necessary in this case.
And we had few cases in the last 3 years. We have seen about 5 cases like this. We continued with antithrombotic and anticoagulation. Almost the angiogram was normal at a follow-up. And of course, we continued antiplatelets and drugs. Thank you.